Not all battles are visible, and neither are the victories. Brittany Burgunder. Imagine a little girl wiping away a tear in silence because she's been told that strong girls don't cry, learning early that vulnerability undermines respect. Long before the word stoic enters her vocabulary, she senses that showing pain, even a mild ache, could shift others' perception of her from capable to fragile. This lesson is not subtle. Researchers in emotional development report that girls as young as 4 begin to receive messages to be nurturing and obedient, whereas boys are praised for self-reliance and toughness. Over time, this early conditioning becomes a hidden curriculum, teaching girls that their discomfort is negotiable and something to be managed privately rather than shared openly. As adolescence unfolds, the stakes rise. Young women internalize the notion that confession of pain is synonymous with drawing negative attention or risking social exclusion. A seminal essay in Time revealed how self-silencing exacts a steep health toll, linking chronic suppression of needs to depression, anxiety, and even autoimmune disorders. When a teen whispers, "I'm fine," despite a migraine, she's not merely avoiding discomfort, she's protecting her emerging identity from labels of weakness. These survival strategies, born of social expectations, begin to carve neural pathways that equate emotional expression with danger. Entering adulthood, these lessons infiltrate every sphere: professional, medical, familial. Studies on medical interactions show that women's reports of pain are systematically underestimated or dismissed, reinforcing the belief that their sensations are exaggerated or emotional in origin. When research further indicates that individuals who experience pain invalidation are more likely to underreport their symptoms in future medical encounters. Thus, the very institutions meant to alleviate suffering instead teach strong women to retreat into silence. Beyond external disbelief, many women become adept at masking not only their pain but the fear of appearing weak. Psychologists studying masking behavior note a pronounced gender gap. Women mask negative emotions more extensively than men, driven by social pressures to conform to roles of agreeableness and self-sacrifice. This skill, useful in navigating professional settings and close relationships, means that the internal alarm bells of pain are frequently muffled, even to one's own awareness. Underpinning all of this is internalized sexism, the unconscious absorption of societal messages that a woman's value lies in her capacity to endure hardships quietly. Research links internalized sexism to a host of physical symptoms, from chronic headaches to digestive issues, as well as diminished self-worth and reduced help-seeking behavior. When admitting pain threatens the very principles by which a woman gauges her strength, hiding it becomes a form of self-preservation. Understanding this intricate web of social conditioning is vital. It reveals that the silence around women's pain is not born of weakness, but sculpted by a lifetime of lessons that true strength demands concealment. Imagine a woman who rises before dawn, packs lunches, runs board meetings and volunteers in her community, every inch a portrait of resilience. Yet she carries a silent storm of aches behind closed doors. For many, admitting pain feels like fracturing the image of invincibility they work so hard to uphold, so they swallow discomfort rather than risk being seen as vulnerable. Research tells us that over 2/3 of chronic pain sufferers are women, and despite their suffering, they often underreport symptoms to avoid stigma. As Professor Choshin Hillel warns, Our research reveals a troubling bias in how women's pain is perceived and treated in emergency care settings, illustrating how systemic underestimation teaches women that their pain is negotiable rather than non-negotiable. She issued this caution after analyzing thousands of emergency department reports, where female patients consistently waited longer for pain relief and were prescribed fewer analgesics. Equally compelling are the biological dimensions at play. Both males and females develop pain, but each sex develops it through different means, observes Dr. Trang, highlighting how his team uncovered a mechanism in which T cells bearing the hormone leptin drive neuropathic pain in women, while in men, microglial channels are the primary culprits. His discovery dispels the myth that women's heightened pain reports are purely emotional. Instead, it frames their strength as a response to genuine, sex-specific biological adversity. When pain is so deeply rooted in cellular behavior, the IUI act of hiding it becomes an act of survival, a way to preserve dignity in the face of incomprehensible suffering. Beyond biases and biology, the very essence of pain merges sensation and self. Pain is part sense, part emotion, part feeling, part qualia, and it's fundamental to the notion of who we are, reflects Dr. Seymour as he models pain perception through computational and neuroimaging techniques. By treating pain as a bomb, complex signal intertwined with learning, expectation, and survival instincts, he illuminates why women, conditioned to anticipate doubt, might mute the alarm bells of their own bodies. When the mind learns that expressing pain invites disbelief or dismissal, that nervous system lesson becomes etched. Stoicism transforms from character flaw into necessary armor. These interlocking truths, social prejudice, cellular complexity, and the psychology of belief, explain why admitting pain feels impossible for so many strong women. They have been schooled by culture to smile through setbacks, taught by healthcare systems to doubt their own sensations, and confronted by biology that amplifies both pain and the need for secrecy. In choosing silence, they safeguard their roles as caretakers, leaders, and keepers of composure, even as their bodies cry out. Understanding this hidden struggle is the first step toward forging a new narrative, one where acknowledging pain becomes an act of self-respect rather than weakness, and where compassion replaces skepticism in every clinic, boardroom, and home, finally granting strong women the grace to be human. Picture a bustling emergency department where the clock seems to mock the woman clutching her abdomen, her face pale and knuckles white, yet every plea for relief drifts unheard. The lights glare as if to say, "You should be tougher." This is not imagination. It's the reality for countless women who present symptoms identical to men's yet receive markedly different responses. A landmark survey found that women with acute stomach pain waited 33% longer than men before receiving any analgesic, a disparity that translates into needless suffering and erodes trust in caregivers when lab reports point to inflammation and imaging confirms distress. Women's accounts are still too often met with skepticism or reframed as emotional. The Washington Post documented cases where women describing relentless headaches were dismissed as dramatic, only to discover later that a brain tumor lay at the root of their agony. Medical gaslighting, a term for when providers attribute physical symptoms to stress, hormones, or mental health, leaves women doubting their own bodies and reluctant to seek further help. 4 experts recently highlighted that dismissive responses not only delay diagnosis, but inflict emotional trauma. Akin to a second injury, these patterns are not anecdotal. A systematic review of women's experiences in healthcare revealed that 72% reported being told their symptoms were all in their head, while 71% felt their concerns were dismissed outright. Such invalidation doesn't simply prolong pain. It rewires a patient's willingness to speak up. Research shows that those who face gaslighting are significantly less likely to report future symptoms, even when conditions worsen. In this silence, serious illnesses can progress, unchecked, and chronic conditions spiral into deeper debilitation. Behind these statistics lies a web of implicit bias, subtle, often unintentional assumptions about gender and pain tolerance. Centuries-old stereotypes portray women as more emotional and less biologically resilient, a narrative inherited by modern medicine despite advances in science. When a woman learns that voicing pain invites doubt rather than care, she adapts by concealing discomfort, trading honesty for what feels like safety. This coping mechanism, though protective in the moment, exacts a steep cost on long-term health, mental well-being, and the very concept of patient-provider partnership. To disrupt this cycle, healthcare must move beyond checklist diagnoses to genuine, compassionate listening. Patients benefit when clinicians validate experiences, clarify treatment options, and collaborate on pain management plans. Equally, women can empower themselves by documenting symptoms, asking for clear explanations, and seeking second opinions when needed. Only by recognizing and rectifying medical bias can we transform the doctor's office from a place of dismissal into a sanctuary of healing, where every woman's pain is acknowledged as real, urgent, and deserving of relief. Behind the stoic facade lies a complex choreography of nerve endings, immune sentinels, and hormonal rhythms, sculpting every pang of discomfort. When tissues endure stress or injury, specialized nociceptors convert chemical or mechanical changes into electrical impulses that race along peripheral fibers to the spinal cord and up to the brain's pain centers. These sensors, ranging from heat-specific to pressure-sensitive types, weave together an orchestra of signals that inform the brain of each potential threat. These nociceptive messages paint sensations in vivid hues, from sharp stabs to dull throbs, but they are constantly tuned by estrogen's ebb and flow. At lower estrogen levels, spinal microglia adopt a pro-inflammatory stance, releasing cytokines that magnify pain transmission and turning a paper cut into what feels like fire creeping under the skin. In contrast, when estrogen peaks, it engages inhibitory pathways that buffer these signals, explaining why women can feel stronger or weaker at different points in their. Adding depth to this picture, women's chronic pain systems often bypass microglia and tap into adaptive immune circuits. Animal studies reveal that while male bodies depend largely on microglial activation for neuropathic pain, female bodies recruit T lymphocytes to infiltrate the spinal cord and secrete signals that sustain hypersensitivity even when microglial routes are blocked. This alternative immune route plays out not just in lab animals, but in women coping with chronic shingles, neuropathies, and long-haul symptoms of viral illnesses, making an injured wrist remain a source of pain months later and turning routine, gripping or typing into painful reminders of an event long past. Hormones extend their influence beyond circuit tuning. They can trigger the body's own opioid factories. Emerging research shows that estrogen and progesterone prompt specialized regulatory T cells in the spinal meninges to release enkephalins, natural peptides that bind opioid receptors and quell pain. These enkephalins act like an emergency relief squad, surging to protect against discomfort. But when hormone levels fall, the squad abandons its post, leaving women vulnerable to the same nerve injury that moments before evoked mild tingles. Layered onto this is the reality of autoimmune vulnerability. Women shoulder the bulk of autoimmune diseases, from rheumatoid arthritis to systemic lupus, where the immune system attacks healthy tissues and ignites widespread inflammation. Inflamed joints, burning rashes, and deep bone aches become unwelcome companions. This silent battle leaves women fatigued, navigating daily tasks beneath an invisible weight, and often choosing to shoulder the burden alone. Voicing that torment can feel like pouring gasoline on the stigma of weakness. So many women opt for silence as their refuge. Beyond peripheral circuits lies the brain's own ability to learn pain through central sensitization. Females demonstrate heightened central sensitization, a phenomenon where repeated nociceptive input strengthens synaptic connections in pain-related regions, so that even mild stimuli provoke intense responses. It's as though the brain writes a horror script about pain, and every cue, sound, touch, even memory, becomes a trigger for agony. Glial neuron crosstalk cements this memory, and emotional centers tag each pain event with stress, so that a simple movement can awaken layers of past suffering, trapping many women in an unrelenting feedback loop of amplified signals. Confronted with bodies wired to magnify agony through hormonal shifts, immune detours, and neural plasticity, hiding pain becomes a human strategy for survival. In choosing silence, women protect their dignity and maintain their roles, standing tall amidst a biochemical storm that no armor could fully withstand. Imagine stepping into a clinic where your pain is met with attentive questions rather than raised eyebrows, where each symptom is gathered like pieces of a puzzle rather than waved away as all in your head. In May 2025, the American College of Obstetricians and Gynecologists released Committee Opinion No. 9, stressing that in-office gynecologic procedures, from IUD insertions to cervical biopsies, demand a patient-centered approach that begins with open-ended inquiries. Can you describe how this pain affects your daily routine? And uninterrupted listening. These guidelines recommend routine use of local anesthetic techniques alongside non-steroidal anti-inflammatory drugs to provide immediate relief, while offering sedation options for more invasive steps, shifting the paradigm from merely tolerating pain to actively managing it. Central to this framework is shared decision-making, in which women explore a spectrum of pain management strategies: topical anesthetics, paracervical blocks, pelvic floor physical therapy, and mind-body techniques, before defaulting to stronger interventions. Rather than a one-size-fits-all, protocol treatment plans are tailored to each woman's unique physiology, lifestyle, and comfort levels. For example, many in-office procedures now allow patients to choose between lidocaine cream, lidocaine prilocaine spray, or paracervical block combined with NSAIDs and guided breathing exercises, empowering women to voice their preferences and take active roles in their care. Beyond clinic walls, patient advocacy is driving meaningful change. Women are urged to keep detailed pain journals, logging triggers, intensity, duration, and emotional context to transform abstract suffering into concrete data. Armed with this information, they engage in constructive dialogues with providers, asking for clear explanations of test results, requesting second opinions when needed, and inviting a trusted friend to appointments for both emotional support and an extra set of ears. Such documentation and support help dismantle the notion that pain is a private shame, reinforcing that every woman's experience merits attention and respect. Time telemedicine has opened new channels for women in remote areas to access specialist consultations and pain management expertise. Studies of hybrid care models show that virtual encounters can successfully establish diagnoses and formulate interventional plans, reducing barriers of distance and stigma. Springer link. At the same time, virtual advocacy training, such as the U.S. Pain Foundation's Introduction to Pain Advocacy and Policy series, teaches participants how to articulate their experiences, navigate healthcare systems, and engage with policymakers through interactive sessions on self-advocacy, policy impact, and effective storytelling. As momentum builds, professional societies and patient groups are co-hosting symposiums that center women's lived experiences, ensuring policy and practice reflect real-world challenges. By embedding validation at the heart of care and training new practitioners in empathy-driven communication, these efforts challenge centuries-old assumptions and pave the way for clinics where acknowledging pain is an act of self-respect rather than weakness. This collaborative momentum offers a lifeline, embedding empathy and shared wisdom into every patient encounter.